Okay. Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. M.S. Hiramat sir. Sir is director at Cath Lab Ruby All Pune, President CSI 2017, Program Chair CSI Conference 2016, Convener National Interventional Council of India CSI between 2004 to 2006. Sir has proctored many interventional cardiologists and has given live courses across the globe. Sir has great experience in peripheral angioplasty, including legs, iliac, and carotids. Sir has participated in some groundbreaking clinical trials also. Sir couldn't join today's program as he's not keeping well, but he told us not to cancel today's event and suggested that moderators can take this program ahead today. So we thank sir for his continued commitment and guidance to us for running this program successfully. His expertise and fan following has made this program a resounding success. Our distinguished moderators, Dr. C.B. Keshavamurthy sir and Dr. Praveen S.V. sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against this global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. C.B. Keshavamurthy sir is Chief Consultant Interventional Cardiologist and Head of the Department at Manipal Hospital, Mysore. Sir is past President of CSI Mysore Chapter, pioneering work in primary angioplasty at Mysore. Sir has established interventional cardiology centers at Salem and Erode in Tamil Nadu and performed several first ever procedures in that region between 2000 to 2004. Sir has several national and few international publications and presentations to his credit. Sir has teaching experience as DNB teacher at Vikram Hospital, Mysore. Sir also worked as principal investigator for landmark trials like Rocket AF, Reduce It, Credence, and Horizon. Sir has also experience of being an investigator in 33 other national clinical trials and registry participation as primary and co-investigator. Thank you, sir, for joining today's meeting. Let me have honor to introduce our moderator for today, Dr. Praveen S.V. sir. Sir is Senior Consultant Cardiologist and Heart Transplant Coordinator at Kerala Institute of Medical Sciences, Thiruvananthapuram. Sir has also participated as clinical trial investigator in IVL, as co-investigator, Tuxedo-2 as principal investigator. Sir has also worked as esteemed faculty in landmark conferences on interventional cardiology like Sing Live, India Live, EuroPCR Paris, TCT AP Seoul, ICCK, SCIP, then IJCTO, NIC Cochin, and India Live Delhi. Sir also worked as expert panelist in CSI 2021 Cochin. Sir did case presentation on complex PCI in 2021 virtual conference. Sir is fellow of European Society of Cardiology. Sir is fellow of Society for Coronary Angiography and Interventions and MNMS. Sir has presented several papers at National CSI Mumbai 2005, and he has published various papers in national and international journals. Thank you, sir, for joining today's meeting. I would also like to extend a warm welcome to our speakers for today, Dr. Amit Thopte, sir. Sir is consultant cardiologist and head of department at Anand Rishi Ji Hospital and Medical Center at Ahmednagar, Maharashtra. The topic which he will be presenting today is anomalous origin thrombotic lesion case. Thank you, sir, for accepting our invitation to present the case. Let me have honor to introduce our second speaker for today, Dr. Basavaraj Sutar, sir. Sir is consultant and interventional cardiologist at Yashodhara Hospital, Solapur, Maharashtra. The case which he will be presenting is AVJ ablation and CSP in post-partial AV canal defect repair. Thank you, sir, for accepting our invitation to join today's program and present a case. Finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected moderator, Dr. C.B. Keshavamurthy, sir. Then there will be first case presentation by Dr. Amit Thopte, sir. Second case will be presented by Dr. Basavaraj Sutar, sir. After every case, there will be a discussion where moderators and the speakers will discuss about the case. Once you are through we are through the second case, there will be concluding remarks by our esteemed moderator, Dr. Praveen S. V, sir, and then it will be followed by a vote of thanks. So I request audience to post their questions in the chat box, and we'll take up those questions at the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. Now I request Dr. C.B. Keshavamurthy, sir, to share his opening remarks and set the context for today's meeting. Over to you, sir.
Thank you, Dr. Rishikesh. A warm welcome to, along with my co-moderator and the presenters, to all the audience who have taken that time off to join this discussion. Thanks to Emcure for setting up this program. It's such a wonderful nationwide program, which is totally educational. And like Dr. Rishikesh commented, it's a bridge between theory and practice, which we really need in our day-to-day practice to learn these things and apply whatever we learn here in this fora into our practice and thereby benefit our patients and improve their outcomes. With those brief remarks, I welcome you again and thank you all for being here. And I hope it will be a wonderful experience and every minute of it is worth it. Being present here is worth it. And I now invite Dr. Amit. We have two very interesting cases today, very different and different sounding. And of course, they'll be interesting to us as cardiologists in our field. Every case is a new experience, new learning experience, and we learn a lot from each and every case. Dr. Amit will tell us how we dealt with this anomalous right coronary, which had thrombus, which is a double challenge, I would say. Thank you, Dr. Amit. You can share and start your presentation.
So you can make it full screen. Yeah.
Today's topic for case presentation is acute coronary syndrome, anomalous origin and thrombotic lesion. These were two challenges. Myself, Dr. Amit Thopte, I passed my DNB cardiology from Jaslok Hospital, Mumbai, and recently I was awarded with EPSCI, USA. So case goes like this. The 55-year-old lady presented with a history of chest pain. She had history of type 2 diabetes mellitus and she was on regular medication for that. Heart rate was around 88 beats per minute regular. BP was around 130 by 76 mm of mercury. Cardiovascular system was normal. There was no murmur. On respiratory system, there were some basal threats. ECG showed evolved inferior wall MI. We did screening 2D echo, which showed mild LV systolic dysfunction with LVF of 45%, hypokinetic basal inferior wall, type 1 LV diastolic dysfunction, and prop T was positive. So we projected this patient for the coronary angiography, and these are the shoots. So in this, we can see RCA has an anomalous origin from the left cusp. It is very close to the LMCA, and the proximal RCA has total thrombotic occlusion. These are the other shoots which we can see. There was retrograde collaterals which were filling the distal RCA from the left system. This slide is not.
Go to the next one. It's just showing the same anatomy left system.
Okay, in this view, we can see the catheter is engaging in the left system, and then simultaneously it is engaging into the right system. We can see the proximity of the RCA ostium with the left main. And this is a two-dimensional. Basically, we can't see the three-dimensional thing. So we can't have exact location of the RCA, whether it is coming anteriorly or it is coming lateral to the left system. See the left system which is filling, and then consecutively the right system which is filling. So our plan was to tackle the thrombotic lesion of the RCA, which is having anomalous origin from the left cusp, which is probably coming close to the LMCA, and the origin is anterior. When we imagine the 3D picture. So various catheters we tried. Initially, we tried right system catheters. First, we use our Judkins right, then 3D RC catheter, then AL1 catheter. We tried for almost 30 minutes, but we couldn't engage selectively. Then we tried the left system catheters, as the right coronary origin is close to the LMCA. We thought the catheters which are engaging the left system will engage the right coronary, as it is coming close to the left main. So we tried first JL, Judkins left. We can see in first video, the guide we took close to the left main origin. Then we slightly turned it to the anterior. Then we, in a reverse fashion, we tried to engage the right coronary origin. But it was not giving support. So my colleague technician asked me to take EBU catheter, and he said, "Sir, we will try this because probably it will have a good support with that." So in next video, we can see the EBU catheter with the support from the opposite aorta. We first engage the left system, and then with gentle maneuvering, I put the catheter close to the right coronary origin. So here we can see in the second video, it is engaging the left system, and then the slight dye which is filling in the right system. Then this hanging wire technique I used to see when I was in residency. Dr. A.B. Mehta sir used to wire various anomalous coronaries with this technique. This technique is you have to get the catheter close to the coronary which you have to tackle, and then blindly you have to maneuver the guide wire, and once the guide wire is in the distal part, you can roll the guide over the wire. So in first video, we can see the guide wire is blindly gone into the right coronary, and then in second video, we can see as per the course of the wire, we can see this is the RCA and this is in the distal RCA. And we can see still the catheter is way away from the right coronary ostium, and selecting engagement was not possible. After this, we had two thoughts, whether to take a guide liner, guide extension catheter, or whether to have a balloon anchoring technique. So we had both the options, but we gone with the balloon anchoring technique. So with 2O balloon, it passed the lesion. We dotted there. We can see in first video, we are in the mid segment. From the proximal segment, we went across the lesion and into the mid segment. And then when we pulled the balloon and we enrolled the catheter to engage the RCA. So in second video, you can see the catheter rolled and it engaged RCA selectively. And we can see the shoot, the proximal thrombotic lesion. So the guide liner or guide extension catheter was not required, fortunately, here because of balloon anchoring technique. So it pre-dilated with the 2.5 into 10 mm balloon. So in first video, we can see the distal RCA was also seen to be having disease. So we have not inflated balloon, we just dotted once and thought we will give some coronary vasodilators. And if the lesion persists, then we will have a balloon dilatation in the distal segment. So coronary vasodilators were given, nitroglycerin and nicorandil, and we can see the distal lesion disappeared. So we can stent now the proximal to mid segment of the RCA. Now, after this, we thought whether to take two stents so that the stent delivery will be easy, or whether this guide is so supportive, one stent can place across the lesion. So the tactile feel of the guide was that I decided to take a single stent, which was long. So the segment was stented with 2.75 into 38 mm of Zane's expedition stent. We dilated at 12 atmosphere pressure. And post dilation done by 2.75 into 8 mm balloon. We sequentially dilated from the distal segment to the proximal segment. And these are the shoots, final shoots. So before intervention, the lesion was, and after intervention. After 1 week, we had a similar second case. This was a 60-year gentleman presented with angina. ECG showed inferior wall MI, which was thrombolized outside. 2D echo was showing LVF of 45% with mild hypokinesia of inferior segment. So we subjected patient for the coronary evaluation. The coronary angiography showed RCA from the left cusp. We can see in second view this is radial tiger catheter, which momentarily showed the right system filling after the left system, and it came out. So during angio only, I thought the support of the catheter will be a problematic issue during angioplasty. So we can see in second video, the left RC originating from the left coronary cusp, and which is very close to the left main, but the origin is slightly slanted and slightly anterior probably. So as we had a case 1 week prior, so we directly started with a Judkins left. We tried to engage with Judkins by keeping it close to the left main and tried with the hanging wire technique. But it failed. Then we attempted with the EBU. EBU also used to go in left system, but the selective cannulation or the stability of the EBU was not great. We blindly put the cyan blue guide wire, but passing across the lesion was difficult. And during passing the wire in the distal RCA, the whole assembly came out. And again we tried, but we failed. Meanwhile, we took balloon support also to cross the lesion, but the wire was not crossing. As the support was not sufficient, then we attempted the cannulation with radial guide catheter. This radial guide catheter has a shape which is similar to Judkins left, but it is slightly opened up. So here we can see it is engaging the left system, and I'm trying to maneuver it clockwise to come anteriorly and to engage it. And at one moment it engaged, but because of the more torsion on the catheter, it came out. And again we tried for half an hour, but we couldn't engage the catheter. So more than 300 ml of dye we used for this procedure. So we thought we will stop here and we will take both the approaches, radial as well as femoral, next day, and we will go with the new state of mind. So next day we took radial as well as femoral, but it was very easy to cannulate from the radial catheter. This is a M radial guide catheter. This catheter easily cannulated the right system. We wired it, redilated with 2.5 into 10 mm balloon. We put 2 stents because the catheter support was not great with this M radial catheter. 3 by 24 mm stent. We stented the mid segment and the proximal segment with 3 by 20 mm. Post dilatation was done with 3 by 8 mm balloon. And this was the final shoot. So PCI in an anomalous RCA can be technically difficult because selective cannulation may not be easy. Special guide wire manipulating skills like hanging wire combined with balloon anchoring technique provided excellent angiographic visualization and sound guide support for the stent delivery. Guide catheter selection should be appropriate based on the origin of the RCA. We chose 6-French Judkins left guide catheter, but it has a bad coaxiality and repeatedly ran off from the RCA ostium. Then we took 6-French EBU guide catheter, which was coaxial and provided good support during the procedure. Here we pre-dilated before delivering the stents and utilized the balloon catheter anchoring technology to induce sound backup and perfect coaxiality for the guide catheter. In second case, we changed approach from femoral to radial, as well as use of M radial guide catheter helped to engage selectively. Thank you.
Thank you, Dr. Amit. That was a great presentation. 2 cases presented very well and managed very appropriately, and a very good successful result. And the case is now open for discussion. My co-moderator, Dr. Praveen, do you have any comments or? we'll just open the discussion. Coronary anomalies are quite frustrating. Many a times it leads to long fluoroscopic times, use of multiple hardware, and very frustrating sometimes when you cannot locate ostium. You feel you're very close, but you're not able to engage that. So you're taken almost all the steps to kind of engage the arteries, like using an EBU or an AL1 guide. For down-looking ostia, like in the second case, you can try a multipurpose, but of course it's kind of specific to the case. You cannot generalize and say that this catheter will engage and you'll have a good result. But once you get a slight engagement, I would say that you should use all the material available up front. Like you said, you want to use a guidezilla, or you want to put a second wire and get the support, or you do a proximal balloon anchoring up front, not after the difficulty, because you would have engaged with a great amount of difficulty, and especially in your cases, they were relatively acute MI cases and easy to cross. But if you have say a CTO, or you have a kind of a chronic lesion where there are difficulties or tortuosities, use all the things you have up front so that your success rates will be higher and you don't lose access. Use a proximal anchoring in a synodal branch, or a distal anchoring to deliver the stent. Or sometimes when you have RCA and circumflex ostia arising close together, both anomalously, put the wire and anchor the wire in the right coronary artery when you are intervening on the circumflex. Take the support of that artery. Always do these things up front, and that's what I would do. And in the first case, I think you undersized the stent a little bit, because one thing I would like to say is, in the presence of thrombus, there is intense vasospasm of the vessel in acute MI. And whenever you see a thrombus, you tend to undersize the stent by about 0.5. Always keep it in the back of your mind, because especially the RCA, you know that it arises and throughout its course it continues at the same size as compared to the left system, where after the branching occurs, the LED tends to taper or the circumflex tends to taper. But RCA, if you see from the point of origin to the point of bifurcation into PD and PLV, it almost remains the same size. So I would have put a 3 or even a 3.5 for that matter. Yeah, so these are some of the points, but now, of course, the case is open for discussion. Dr. Praveen, you have any comments you can make?
Yeah, hi. The second case, was it really from the left sinus, or is actually from the right only, bit high up and more closer to left sinus? That's one doubt I have. And as you said, elegantly demonstrated the hanging wire. That is often useful. And we also have encountered similar sort of scenario where after the hanging wire, I have usually taken a small balloon to take in, anchor, and then over that immediately take the guide in. And there was one case where we couldn't engage with any of these. And as Dr. Keshavamurthy told, I think radial is often more helpful than femoral in these sort of cases.
Yeah.
Right?
Yeah.
Otherwise,
some cases where no guidings would engage, what we have come with a Tiger catheter, like you did, Tiger diagnostic, then put a wire and kind of anchor that, and then remove that and replace it with a guide with support of another wire. Yeah. Yeah, Dr. Praveen, sorry I interrupted you. You were saying.
That was one I want to highlight. Yeah, we have tried in one case where actually we have to take the radial diagnostic catheter and we have to exchange that catheter with a guide and do the procedure.
Yeah.
Otherwise,
Good.
it's a certain case. Good result. Final result is good.
Yeah. Any comments in the chat box? We'll try to answer that, or we'll go out and do it at the end. That's also both are okay.
Yeah, sir. We can take up at the end if there are any comments. We'll try to take up at the end.
Sure. Thank you, Dr. Amit. And we'll now move on to the second presentation. Dr. Basavaraj will now present a very interesting case of ablation, AV nodal ablation in the coronary sinus spacing.
Dr. Basavaraj, sir, you can share your screen.
My slides are seeing, sir?
Yeah, it's visible, sir.
Okay. Yeah, you can go ahead with the presentation.
Okay. Good evening, sir. I'm Dr. Basavaraj here. I'm working as an intervention cardiologist and electrophysiologist in Solapur right now. So I am presenting one case. Yeah, actually, this case is related to tachycardia, tachycardiomyopathy, which is related due to air. Slides are not.
Is it moving? Yeah, it is moving, sir.
The 54-year female post intracardiac repair for partial AV canal defect with MU repair in 2001 and Rudo MVR in 2021. He had admitted for recurrent heart failure with AF with fast ventricular rate, and she was admitted with worsening dyspnea from class 2 to class 4, and she is refractory to DC cardioversion. Multiple times we have attempted cardioversion, but she is still in AF, not with optimum medical management also is not improving her symptoms. So this is a ECG showing irregular heart rate with broad QRS complex LBBB pattern. Initially, we tried everything with medication, with amiodarone, digoxin, then diuretic infusion, and still she is persistent in hypotension with inotropes. Multiple times we attempted cardioversion, but still she is in AF with fast ventricular rate. So for this case, we are thought of give treatment. The multiple choice of options are available for this patient, but we already tried cardioversion multiple times, but she's not giving response or refractory to the cardioversion. Another one is the role of AF ablation for this patient, but in view of economical constraint, she is not able to not consider ablation or cryoablation. So another one role is for this patient is AVJ ablation, which was rate control therapy for this patient with heart. So patient was initially we thought like we'll go for AVJ ablation. We'll first of all manage the heart failure right now, and we'll go for AVJ ablation, CRT or CSP. But economically she's not so good, so CRT also we are thought is not able to good for this patient. Another option is a conduction system pacing, one of the good option with AVJ we thought. So initially we put temporary pacemaker, screwing lead we used, and prior to AVJ ablation, and patient is stabilized first with medication. We did temporary pacemaker with screwing lead, and provisionally diagnosis for this time is like AF with fast ventricular rate, LBVP, admitted with acute decompensated heart failure, and we plan for AVJ ablation and CRT or CSP. As this patient has AV canal repair prior 2001 and 2021 redo MUR we already done. So it is a difficult anatomy for AVJ ablation for this patient, because anatomy for partial AV canal defect, we always saw like the AV node is displaced posterior-inferiorly, and relatively short distance between the AV node and origin of the left bundle branch, and marked posterior-inferior displacement of left bundle system is a problem for this patient to ablate the AV compact node. So this anatomy, considering this anatomy, we tried first right-sided. We ablate the AV compact node, but it's very difficult to ablate from right side. So we decided to go by left approach, by retrograde approach, to ablate the AV compact node first, and then we'll plan for CSP or CRT. So these are the HV. We got initially we approached right sidely, but is not able to ablate on right side. These are the pace rhythm. When we first already put pacemaker, temporary pacemaker, then we ablated from left side. From left side, retrograde approach, we ablated AV compact node, and then these are pace rhythm after ablation or AV compact node. These are the pace rhythm you're seeing after ablation. And post AVG ablation, the pace rhythm with 12 lead ECG is showing ventricular pace with temporary pacemaker. And then the next day after stabilization, we planned conduction system pacing for this patient. These are the EGM, baseline EGM during the conduction system pacing. And once initial QRS duration is around 120, 28 milliseconds, a little bit wider initially. Once we are CSP done, after that we got elevate around 74 milliseconds and good current of injury with CSP lead. During CSP conduction system pacing, we got fixation beats, which was the indication we could catch the left bundle area, and this was a good sign during the CSP implantation. And these are the different morphology we got during the CSP. One is if we got there is no only left ventricle septal left ventricle septal. There is no any left bundle capture. Then we got like QS pattern. When we got non-selective LBB area pacing, then it is a QR pattern. And when we got RV capture only, then it is only QS pattern we will get like during the screwing lead, so CSP screwing lead. So post CSP, this is the post CSP. You got like V1 showing QR pattern, which was the indication of you got like selective LB capture, which was in the V1. And this is a post CSP pacemaker. So post procedure patient was improved symptomatically from class 3 to when she came is around class 4, class 3, and before proceeding the it went into class 2, and she is improved. LV also improved after 7 days. We got only LV around 48% during discharge, and follow-up patient is doing well. So in conclusion, the heart failure is common in any tachyarrhythmia. Focus to eliminate the cause or control the arrhythmia is one of the important key factor for any tachyarrhythmia related cardiomyopathy. So in this patient, is difficult to manage because all methods are used to stabilize her, but last option we got like AV junction ablation and pacemaker. So AV junction ablation, relatively simple and safe procedure, can be used and any benefit of a specific subset of patients like atrial fibrillation with heart failure. Actually, this case is not related like thrombosis, but I wanted to present like any heart failure with tachyarrhythmia related cases. If AF is not under control, we can use this newer method also to make patients stabilize and symptomatically improve. That is on AVJ ablation of CSP or CRT. For this patient, we use like AV junction ablation with conduction system pacing. Thank you.
Thank you, Dr. Basuraj. That was a great presentation. We all know that structural heart disease with arrhythmias, and especially when patients present with tachyarrhythmia and tachycardiomyopathy, it's an extremely difficult situation. There are multiple options based on the recent trials. The AF ablation seems to have a very significantly beneficial effect. Classically, we were taught that rate control versus rhythm control in chronic AF is a better option, but now we have learned that in this, when you select the patients properly for the kind of ablation, they do extremely well with respect to improvement in ventricular function and also control of rate, as you have so beautifully demonstrated in this particular case. And very happy with the outcome of this case, and patient got well. Selective AV node ablation has been a procedure which has been considered in refractory AF for quite some time. But we have to select our patients very carefully because AV node ablation by itself carries a mortality as an adverse effect, because AV node ablation independently has a mortality of about 2%, if I'm correct. So, and it permanently commits the patient to a pacemaker. So these are two things which we always have to keep in mind. But of course, now we have selective left bundle pacing or conduction system pacing, and we can get away with that in patients who cannot afford a CRTD and other types of resynchronization therapies. So extremely well done and well handled, and a patient has done well. That is what is most important for us, irrespective of what efforts we take. Finally, the patient should do well and have a good outcome. That's what we aim at. Now the case is open for discussion. My co-moderator, Dr. Praveen, can make his comments, and then we can read the chat box.
Thank you. So, Basavaraj, one doubt. Why didn't you consider actually an AF ablation in this case? Sorry if I didn't follow the case correctly.
Affordability means
Affordability is the problem, sir, this patient.
Okay, fine.
We considered AF ablation for this patient.
Yeah.
One thing, she underwent already MVR one, and anatomy was somewhat different. So initially we thought we'll do AF ablation, but economically somewhat difficult for them. So we thought we will go for AV node ablation and pacemaker, and they agree with this. That's why we selected this one.
And the second question I want to ask you is two things. What is the post-procedure anticoagulation? Now that the meeting is based on anticoagulation, you follow in this case. And
Yes,
will you definitely continue amiodarone in this case?
Actually, sir, amiodarone will not continued. We anticoagulation acetone will continued for this patient, sir. And beta blocker and beta, because already we have pacemaker. And she is rate control already we did with pacemaker and AVJ. So amiodarone will not continued for this patient, sir. Anticoagulation acetone will continued, and at heart failure management we continued, sir. Optimal medical management.
And would you have considered CS pacing also in this case along with this?
Actually, sir, what happened? This patient is one thing is she is a poor economical one thing, and we thought only we'll do CSP, whatever the minimal economic constraint will give her. That only we tried, but CS we not tried, sir. Actually, this patient, because anatomy was we thought it was difficult, so we not tried that one, sir.
And one more point is it's a tachyarrhythmia where your pacing has actually improved the LV function. But won't you think that in this young lady, over time she's again going to have a worsening of the heart failure because she has a univentricular pacing alone, right? So what is your thoughts on that? I don't know, the long-term data.
Yes, sir. That one issue. But actually, sir, we use the conduction system pacing. Atrial pacing also we use, sir, here, this patient.
So, but how does atrial pacing help in this case? Because he has an atrial fibrillation.
Yes, sir. No, I actually one thing we got is a CSP that can help up improve the LV function. We got the selective LV capture.
No, but then this is actually a case of LV area, left bundle area pacing, right?
Yes, sir. Yes, sir.
LV area pacing alone, will it actually help to improve the EF in the absence of some sort of a CS pacing also?
Actually, sir, for this patient, LVB is the morphology. In these cases, a lot of time we use the left bundle, selective left bundle capture. They can improve the LV function, sir.
Okay, but then you have not put any atrial lead, right? It is only a case
atrial lead, sir. Screwing lead we put the
in the atrial. But how is it going to help? Because even if you have done an AV ablation, the patient is still going to have an AF, right?
Yes, sir. Yes, sir.
So how does an atrial lead in this case? In that case, you should have given the patient the option of an AF ablation, or at least to continue amiodarone, so in the hope that some sinus this thing will happen and you have an AV synchrony, right?
Yes, sir. Yes, sir.
I thought on that. I don't know.
No, it's correct, sir. One actually all other things we considered that patient we went for like same right now to control the heart rate and heart failure. That's what only we got, and we given treatment at that position, sir. That time.
Okay. And of course, okay. Yeah. Okay.
With rate control and all.
Sorry, I interrupted. Sorry, please continue. Please carry on.
With good rate control and with all the 4 pillars of heart failure, patients should have a good improvement in ventricular function for long term. And selective left bundle pacing and conduction system pacing have been shown to have better outcomes in terms of better left ventricular function as opposed to right ventricular chamber pacing, non-selective pacing. Yeah.
So one of the things I would like to add to what Dr. Keshmur is saying is the left bundle area pacing. Of course, this is a young patient, so we need long-term follow-up of her. No, so
Correct.
how it performs over the long term. And the next concern is you have done left bundle area pacing. No, so over time you are sure that the LV is going to improve like this. Maybe you need more follow-up, right?
Follow. Yeah.
See how the LV performs over time.
Yeah, I think if it is purely a tachycardiomyopathy, they should revert to normal in most of the cases with good rate control.
If
Now
it is
that we
only
have fully updated the AV node, the AF should not have much effect on the ventricular rate with good drugs, of course. Yeah. For a period of time, you can try high dose amiodarone. People have tried in these kind of situations with refractory AF, 800 milligram twice daily, up to 1.6 grams per day for a short period. Of course, it's a very toxic drug and you have to monitor for the adverse effects, but give it for a short time till there is good rate control. Then if she can tolerate beta blockers and calcium channel blockers, you can keep.
And what was the LB pacing used? Which product actually? The left bundle pacing lead?
3830 lead we use in Medtronic most of the time, sir.
Okay. Do you feel, I'm frankly asking you as a doubt, is there an advantage of using a Medtronic over the other ones? Or it's
Actually,
just
sir,
purely your experience or our, whichever we feel we are comfortable, that helps actually?
Actually, most of the time we used only Medtronic, sir. Medtronic 3830 lead we used. And
Okay.
we got good result. Actually, my thesis is related to that. We use most of all cases are Medtronic, and we got good result in that.
Okay, so your experience Medtronic is good, as you have tried in a lot of cases.
So,
Anyway, it's a well done case.
very
Thanks
good.
for enlightening us.
Very nicely handled. These are very refractory atrial fibrillations, like I said earlier. Structural RTCs, if they have valve disease and especially the rheumatic variety, sometimes can be very, very frustrating to control the ventricular rate. And as a last resort, you have to get to AV ablation, selective AV node modulation, and with a permanent pacemaker. Yeah. Any comment? Chat box? We can look at the chat box. Thank you, Dr.
Yeah,
Bas-
let me check if there are any. Okay, no, there are no comments so far.
We have
So,
finished time and,
yeah. So, as we approach the conclusion of this program, let's welcome back our esteemed moderator, Dr. Praveen SV sir, to reflect on the invaluable insights we have got today and give his concluding remarks. Over to you, sir.
Yeah. Good evening, my co-chair, Dr. Keshavamurthy also. So we had two good cases. Both of them had lot of teaching points. Like the first case, anomalous coronary. Often we get these cases in the middle of the night and we would be surfing around for hours to search for where is the origin of the coronary. So he has enlightened on that. Of course, that was a very enlightening discussion. And being an interventional cardiologist, I would say the second case was some sort of a learning for me, because the role of an AV ablation, we have seen elegantly that AV ablation. And one point I liked very much was the screw-in lead as a temporary pacemaker for this patient to have a stability during the procedure of AV ablation. And he has nicely demonstrated the left bundle area pacing also. So both had a lot of teaching points. And of course, even though there was nothing so much about antithrombotics in this meeting, the second case highlighted the importance of anticoagulation regimen for these sort of patients. And the thrombus burden in the first case also helped, was adding to the thrombosis topic per se of the meeting. So we would all like that we had almost like two good cases, two good presentations. And I would like to thank both of the presenters. And I would like to thank my co-moderator also, Dr. Keshavamurthy sir from Bangalore. Over to you, the Emcure.
Yeah, thank you, sir. So we are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this scientific program possible. I would like to express my sincere gratitude to our distinguished moderators, Dr. C.B. Keshavamurthy sir and Dr. Praveen SV sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Amit Thopte sir and Dr. Basavaraj Sutar sir for their insightful case presentations. I'm sure everybody enjoyed both the cases. Both were interesting case presentations. and your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time and continued love and support for this no thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Good night.
Thank you, sir. Thank you. Thank you.
Thank you.
Thank you.